Hello, everybody. My name is Stephen, and today I'm going to be giving a presentation on pacemakers and exercise. Some of the things you may learn in this presentation are different types of pacing and some of their clinical implications and how they affect exercise. So first, let's touch on why somebody would need a pacemaker. To a certain extent, you could argue that everybody has a pacemaker in that we all have a sinoatrial node. And what this sinoatrial node is responsible for is the contraction of your heart. Typically, this occurs at between 60 and 100 beats per minute when you're at rest. And so the sinoatrial node is located in the upper right atrium. And from there, the impulse is traveled to the left and right atrium, and then to this atrioventricular node that you can see in this image on your right, and then down and around to both ventricles. Now, so if somebody needs a pacemaker, it is always due to a heart condition that does not allow the heart to beat quickly enough. So that's below 60 beats a minute. However, there are a few exceptions to this. And so we'll talk about that later on in the presentation. However, some of the specific indications as to why somebody may need a pacemaker include sinus bradycardia. This is the sinus node, doesn't beat fastly enough on its own. Sinus pause, and this is when there's a prolonged pause in between heartbeats. Next, we have bradycardia, tachycardia syndrome. This is the heart oscillating in between a very fast rate, which is tachycardia, and a very slow rate, which is bradycardia. Next is heart block, and this one's a little different in that this is not an issue with the sinoatrial node itself, but rather the impulse that the sinoatrial node sends out is blocked at some point in the electrical system of the heart. For instance, let's say there was a block in this electrical system at the atrioventricular node, which you can see in the image on the right once again. In this hypothetical situation, the electrical impulse would be conducted to the left and right atrium completely naturally. However, upon needing the block, this would limit the capacity to contract of the left and right ventricle. The next one's heart failure, and this one's a little different than the other indications on this list. However, the basics of this are the heart does not have the ability to pump an adequate amount of blood out of it into the body. So next, we're going to talk about the types of pacemakers. And so the first one we'll go over is the single chamber pacemaker. And so this is a singular lead that often leads from the pacemaker device to either the right ventricle or the right atrium. The right ventricle is much more common than the right atrium. The next one is the dual chamber pacemaker, and this one does both the right atrium and the right ventricle. When we compare a single to a dual chamber pacemaker, oftentimes the dual chamber pacemaker on average will be able to increase your cardiac output over a single chamber one. And if we think about the reasons why this might be the case, think about the path of blood through the heart. So first it comes in to the right atrium, and then it drops down into the right ventricle. The timing of the ventricle contracting is very important. So in a hypothetical situation, let's say that somebody has a single chamber pacemaker. Now they have a stimulated atrium or ventricle, but they have a chance to be out of sync with each other. So when the atrium drops its blood down into the ventricle, the optimal situation is which the ventricle completely fills to the top. Now, hypothetically speaking, let's say that the ventricle contracts prior to the atrium, releasing all of its blood into it. This would release a volume of blood that's less than it would be if they were synchronized. However, this dual chamber pacemaker allows for adequate time to be spent in between the contraction of the atria and then the ventricle, allowing the ventricle to fill up to its fullest extent and optimizing your cardiac output. Next, we have biventricular pacemakers. And now this is the newest of the three. And so what this does is this carries an impulse to both ventricles, the left and the right. Often what this is seen to help and be indicated for is heart failure. And this assists heart failure in the way that it allows both ventricles to contract at the exact same time. Clinical studies have shown that this improves the cardiac output of heart failure patients. And more specifically, we have non-obstructive hypertrophic cardiomyopathy. And we'll get more into this later in the presentation. However, what you need to know right off the bat is that this condition is the left ventricle is not able to properly expel blood due to perhaps stiffening. And this is in opposition to obstructive hypertrophic cardiomyopathy, which is the muscle of the heart wall is in the way of the exit from that ventricle. Next, we have rate reactive function. In the most general terms, rate reactive function can be thought of as a function that recreates the natural behavior of the sinus node. And so this is common in all types of pacemakers. Technology was developed in the 80s, and this largely replaced fixed rate pacemakers. There's a few different ways that the rate reactive function is activated. And this is in cases where heart rate needs to be elevated past what it would be at resting. So this could be the onset of exercise. This could be a stressful situation or an emotional situation. The first one is a piezoelectric crystal. Now, this detects the activity of muscles. So at the onset of exercise, muscles begin to move. This type of rate reactive function picks up on that and adequately increases the heart rate to meet the demand for the activity you're doing. Next, we have accelerometers and movement sensors, and this just generally detects the movement of the pacemaker around in space. And there's breathing rate or minute ventilation. This detects the rate at which you're breathing, obviously, and is able to adjust the heart rate adequately to meet the demand. So in this study that is mentioned here and in the previous slide, Kaloin et al., it was found that in patients with rate reactive function active versus rate reactive function deactivated, the patients with it activated were able to exercise at a higher workload. And this is 98 watts versus 77 watts on average. So here we are, and this is an accumulation of all of the past slides to this point. So first we have DDDR. And what this denotes is a dual chamber pacemaker with rate reactive function activated. And down here we have VVIR, and this is single chamber pacemaker with rate reactive function activated. The R at the end denotes rate reactive function activated. And now this is compared to regular DDD, which is dual chamber without rate reactive function activated, and VVI, which is single chamber without rate reactive function activated. So on average, in this study, the researchers were able to find that the patients with a dual chamber pacemaker with rate reactive function activated were on average able to exercise at the highest net level of all of the groups. Important to note is that the average for dual chamber and single chamber with rate reactive function activated were relatively similar. As you can see, however, there are a few outliers that are on the right. These are patients in DDD and VVIR that are exercising at a higher capacity than even the dual chamber rate reactive function activated group. This can be explained for a few different mechanisms. One of the more prominent ones is that incomplete AV block, which is a type of heart block that we had mentioned earlier. It seems to be that patients actually perform better without rate reactive function activated. And now the mechanism behind this isn't completely clear. However, it seems to be that when the right atrium and the sinoatrial node are being paced, generally speaking, they seem to allow the pacemaker to do its work. However, in cases when the right atrium is not being paced, there seems to be an increased hormonal activity and natural rate of the sinus node. The choice between these four pacing capacities are highly dependent on condition. For instance, if there is no blockage issues and no synchronization issues, a single chamber pacemaker for the right atrium may be indicated, considering the patient has a slower than normal heart rate, however, no other issues. Or another example is, let's say there is a mild heart block. The single chamber for the ventricle may be indicated, or the dual chamber for both. All right, next let's talk about biventricular pacing. So this is the newest method for pacing, and this has two leads that attach to both ventricles, left and right. And so generally it's been found that this is very useful in patients with heart failure. However, due to its new nature, new applications can continue to be discovered. So, and in this case, we have non-obstructive cardiomyopathy, and this is from the study Ahmed et al. So non-obstructive cardiomyopathy is an inherited disease, affects about 1 in 500 people. And generally speaking, this is an issue in the musculature of the left ventricle, which is the final chamber before blood leaves the heart. And generally what was seen in this Ahmed et al. Study, which I'll show you on this next slide, was that the biventricular pacing did a better job than regular pacing. Regular pacing was denoted by this sham word, as you can see in here. In this study, it was single chamber without rate reactive activating. So that's denoted as VVI. But as you can see, the peak VO2 in patients with the biventricular pacing activated in this study were able to work out at a higher capacity than those with regular pacing activated. And so this just goes to show that cardiac technology is always advancing and it's always finding new applications for new tools. And I'll leave you with just some simple operational considerations as they relate to exercise. So as we all know, physical activity is imperative for recovery and improvement in daily life following a cardiac event. However, there are a few important considerations to take into account before beginning exercise. For instance, the arm on the procedure side, which this will usually be the left side, should not be lifted over shoulder level for 2 to 4 weeks following the procedure. Additionally, the patient should not lift more than 10 to 15 pounds immediately after the procedure. Another one that I found from the American College of Sports Medicine was that strenuous and intense activities, and the examples that they gave were bowling, swimming, golfing, should be avoided for 4 to 12 weeks. And all of these are to protect the fragile incision site of the pacemaker device itself. Generally speaking, light to moderate intensity activity can be engaged in 2 to 3 days after operation. And patients should always consult their cardiologist before beginning a new exercise program. And yeah, that is the entirety of my presentation. I hope you guys enjoyed, and I will see you in cardiac rehab.